A very, very, very warm welcome to this first webinar of the Swiss Implantation Science Network. The Swiss Implantation Science Network was created in 2019 and is connecting all the implantation scientists in Switzerland, is creating opportunities for education, is also showcasing implantation science projects in Switzerland or conducted by Swiss researchers, and also tries to leverage opportunities for funding for implantation science. And our webinar series have become a very important instrument to connect, but also to have an opportunity for experts, international experts and national experts, to convey newest methodological insights or information on the results of implantation science projects. My name is Sabina de Geest. I'm a professor of nursing at the University of Basel in Switzerland at the Institute of Nursing Science. And it is my absolute pleasure to welcome a renowned and a very respected implantation scientist, Dr. Cara C, who is a clinical psychologist, and she's a senior faculty at Kaiser's Permanente, Washington Health Research Institute. And Dr. Lewis is interested in developing strategies to improve the integration of evidence-based practices into real-world settings, and this by developing pragmatic methods and measures. Dr. Lewis is truly an international leader in implantation science and has served as past president of the Society for Implantation Research Collaboration, the CIRC, and is the co-founding editor-in-chief of the CIRC journal, Implantation Research and Practice. She is PI, principal investigator of 2 implantation science centers, and Dr. Lewis is an affiliate faculty member of the Department of Psychiatry and Behavioral Sciences and the Department of Health Systems and Population Health at the University of Washington. We are absolutely thrilled to have Dr. Lewis among us, and we do look forward to really benefit from her expertise as she will talk about articulating implantation mechanisms to optimize for impact, efficiency, and equity. Before I give Dr. Lewis the floor, I just would like to emphasize that although we are virtually connected, we really would like to hear your voice. And in the Zoom world, there is a chat function. So while Dr. Lewis is giving her presentation, please do not refrain from providing your reflections, your questions, your remarks in the chat. We will have ample time for discussion at the end of this presentation. And so therefore, we really look first forward to Dr. Lewis' presentation. She told me she was still fine-tuning just before we started. So it's cutting edge what will be presented. Dr. Lewis, to you the floor.
Thank you for that kind introduction. I'll take a moment to share my screen now. And I believe you're seeing my slides as intended. So, as was mentioned, today I'll be speaking to you about articulating implementation mechanisms to optimize for impact, efficiency, and equity. And if I fail to touch on one of those 3 parameters, I invite you to call me out and we'll have a discussion. I hope we'll have a discussion regardless, but I wanted to start by retelling a story of Elvin Geng retelling a very old story. So if you don't know Professor Elvin Geng, I encourage you to look up his work. He is truly inspiring. He challenges me in my thinking about implementation mechanisms. And when I heard him tell this story at CIRC, the Society for Implementation Research Collaboration, recently, September 2022, I felt it was such a compelling case of why implementation science ought to center mechanisms that I asked and got his permission to retell you his version of this story. And I'm still seeking a psychosocial, or even better, a complex multi-level intervention example to make the case for mechanisms in implementation science. But for today, we will rest on the example of a well-known story of scurvy. So as you all know, scurvy was a devastating disease that killed perhaps 2 million sailors before the 20th century, often claiming half of a crew. And as we now know, vitamin C contributes to the formation of collagenous tissues, the material that keeps your blood vessels, joints, and gums intact. And its absence can be fatal. In 1747, James Lind, a surgeon, tried an experiment that has since made history. His experiment went like this. He got 12 sailors sick with scurvy, put them into 6 groups, 2 in each of these groups, and he gave each group the candidate treatments that you see on the slide. The 2 that got citrus recovered dramatically, while the others languished. This finding is hailed as an early, if not the earliest, successful clinical trial. And Lind has gone down in history as a scientific hero. And however, the results were not successfully or consistently taken up for 50 or even more than 100 years, some observations suggest. Admissions for scurvy at this typical hospital in Britain continued to be high for about 100 years after his experiment made this observation. This is a fabulous example of the no-do gap that frankly inspires our field, implementation science. It's clear that the citrus theory had far less of an effect than it could have at the time of its initial observation. So enter implementation science. And here is where we see and build the case for mechanisms. As with everything that we undertake in implementation science, the truth is far more complicated. So even though Lind found that citrus led to recovery, no one at the time knew the mechanism was vitamin C. So it's sort of tragic in a way, as Lind himself confesses in his final writings on the topic that he doesn't understand what he observed, why it worked. Some captains on ships ended up boiling lemon juice to concentrate it, but this inactivated the vitamin C and sailors still got scurvy. And so there was doubt cast on the citrus theory altogether. In Elvin Gang's words, who retold this story to center mechanisms, he suggests this is really not a story of a man with evidence and the failure of a system to use it because they tried. But it's the story of a society that did not understand the mechanism of the effect. And therefore, they did not understand how to use it, how to tailor it, how to scale it. Intuitively, looking back, if you centered the mechanism, then the implementation mistakes would not have occurred. So channeling another one of my colleagues who I have great respect for, David Chambers at the National Cancer Institute, I wanted to give a quick overview, jumping ahead a few hundred years, of the first 3 decades of implementation science as a field, and how we might characterize the good work that has been done using a single question. So for instance, when the field was first, if you will, legitimized in the 2000s, we were inspired by the preponderance of these no-do gaps. It didn't start with scurvy and it didn't end with scurvy. What we knew and what we were doing in practice were not lining up. You see this chasm or gap between the two. And so the questions that scholars were asking at the time was, what got in the way? What went wrong? The second, and before I move on to the next decade, I'll acknowledge one of the seminal articles that came out during that time. Laura Damschroeder and colleagues published what is fondly referred to as the CFR, the Consolidated Framework for Implementation Research, which can be characterized as a determinants framework. This is a good example of the type of work implementation scientists were producing at the time. It was focused on surfacing what went wrong. Moving forward to the next decade, we saw more and more work then trying to answer the question, well, what works? What works to overcome these barriers, these determinants? And a seminal article from that decade is one led by Byron Powell and colleagues that surfaced a compilation of implementation strategies for integrating clinical and other health innovations into the settings for which they were intended. So we moved from what got in the way to what works to overcome that which got in the way. But we kept, and we still see inconsistencies, that a strategy will work in one setting and not in another. And so fast forward to the current decade, we're now seeking to answer, the field is ready to answer the question, how do strategies work? Under what conditions, for whom, and when do these strategies work? And I'm excited to say that there are several studies our field has produced along these lines, along the lines of centering mechanisms. And you can see more about that in a systematic review that was published in 2020. I will say I spend a lot of my time worrying, not ruminating. It's a healthy type of worry, but I worry about the amount of time implementation studies take, 5 years, 7 years, sometimes 10 years to publish our findings, and the amount of null studies that are being produced. It worries me. It worries me for the sake of our practice partners. And so I'm here today to talk about how slowing down might actually allow us as a field to speed up. And when I talk about slowing down, I really am just trying to encourage folks to slow down and think causally, unpack all of the factors implicated in an implementation strategy pathway, not just for the science, but because doing science in this way might yield greater practical impact. So if you know which path to take to get from A to B, you can practically take action and move in the right direction. And you'll see more about how we're thinking of practical implementation science in our recent textbook that was published just last year. And this is intended as a textbook. It's got teaching syllabi and things like that and slides for you to use, but I also think it can be helpful to the practitioner of implementation as an individual or team. By designing and testing causal pathways, I think we can increase the generalizability of our findings, in this case of strategies. We hear so often, this strategy works here and here, but not over there. I also think practically, if we articulate and test causal pathways, we can inform adaptation. We hear more and more often, there's no implementation without adaptation. And if you center mechanisms, you know what to adapt and what to retain. So I will show you the practical relevance of this throughout the talk today. So if you agree with this sentiment, that by slowing down, articulating our causal pathway, focusing on mechanisms, then it's really about, taking more time to be explicit between points A and points B. But how should we do this? How should we conceptualize it as a field? How should we talk about it? Let's start at the end. I think most of us do. We start an implementation initiative or study because we're trying to achieve a particular outcome. So implementation outcomes are defined by Enola Proctor and colleagues as the effects of deliberate and purposive actions to implement new treatments, practices, and services. In their seminal paper, first in 2009 and then refined in 2011, they intentionally differentiate implementation outcomes from service outcomes and client or patient outcomes. And they talk about this as leading to a cascade. An evidence-based intervention has shown to have an impact on client outcomes. Therefore, if we are trying to bring that evidence-based intervention into play, we should expect those client outcomes to occur if we achieve one of these 8 implementation outcomes. So for now, I'll just plop implementation outcomes over here to the right. That is what we're moving toward. And to make this concrete, let's use an example. So for the example that I'll carry through the next few minutes, we're trying to increase depression screening rates to achieve a guideline that is shown to have a population impact and improve clinical outcomes. So that is our implementation outcome. How do we get there? How do we achieve this implementation outcome? Well, we deploy implementation strategies. These are the methods or techniques used to enhance the adoption, implementation, and sustainability of clinical programs or practices. We now know there are at least over 100 discrete implementation strategies that could be deployed. You can organize them into lots of different buckets or conceptually distinct categories. For you, here are 6 that Byron Powell and colleagues write about in 2011. Examples include of the planning category, we might use needs assessments, site visits. Within the education category, we might conduct educational meetings or dynamic trainings. Within finance, we could use capitated payment systems or alter incentives. Within restructure, we might change systems or revise roles. Within quality management, we might use things like audit and feedback, advisory boards. And within the policy context, we might change requirements or change liability laws. So in the definition itself, it said implementation strategies are methods or techniques to achieve implementation outcomes. So we could draw a line from implementation strategies to implementation outcomes. Staying with our example, an implementation strategy might be to have a decision prompt, a decision support prompt in the electronic health record to alert the team or the clinician to engage in depression screening. Now, why are the implementation outcomes so far away? I thought Proctor and colleagues moved implementation outcomes to be more proximal in nature than clinical outcomes. Well, it is true. In that cascade, implementation outcomes are more proximal than clinical outcomes. But our team thinks more about the importance of articulating even more proximal and even intermediate outcomes, because we should be able to identify earlier signals that our causal pathway is being activated or not. So in this case example, where we're trying to get to a guideline level of a screening rate for depression, we might see as an intermediate outcome that clinicians are administering a PHQ-9. They haven't hit the guideline level yet, but they're starting to administer it. And a more proximal outcome might be that they've endorsed being reminded by the prompt itself. If you ask them on a walkthrough, in a huddle, in a shadow situation, did you notice the prompt in that session? If they say they did, that's a sign that the strategy is working on the pathway that it's intended to support. Now enter determinants of practice, one of our jargony terms that means or refers to factors that obstruct or enable barriers in targeted professional behaviors or healthcare delivery processes. These are often referred to as barriers and facilitators. Krauss and colleagues, in a really interesting multinational study using multiple methods, they uncovered at least 601 unique plausible determinants spanning multiple domains. There, again, are lots of ways that you could categorize implementation determinants. This is just one. And some examples include, at the patient level, there might be beliefs that they hold that are inconsistent with the evidence-based practice, or they might be experiencing social determinants of health or social risk, such as financial strain, that prevent them from coming into a clinic at all. We might, at the provider level, see determinants such as their own attitudes, skills, knowledge, or biases that could even be implicit in nature that prevent them from taking up a new practice with ease. At the organization level, we might see things like leadership or misalignment in culture with the evidence-based practice, or insufficient resources to take on something new, like modifying an electronic health record. In fact, they might not even have an electronic health record. In the community, there could be issues like infrastructure or siloing or competition that makes taking on a new evidence-based practice challenging. And at the policy level, we could see competing mandates or incentives or disincentives to engage in an evidence-based practice. So staying with the causal pathway diagram, or CPD as we often refer to them as, how do these implementation strategies achieve their outcomes? By doing what? So we argue that implementation strategies ought to be selected with an implementation outcome in mind, but the selection becomes easier if you are trying to overcome, resolve, address, or sidestep a locally contextualized barrier. So in our example, we have a barrier that clinicians have divided attention. In a 20-minute patient appointment that is back-to-back seeing 21 patients a day, they are divided in their attention. They're paying attention to the human being sitting across from them. They're starting with the patient concerns, and yet they know depression is so prevalent that the simple act of screening can save lives. It doesn't stop there, of course, but their attention is divided. So the strategy needs to be selected to help overcome this divided attention. So what is the process for resolving that barrier? Enter mechanisms of change. So the reasons why change occurred or how change came about. It is the process through which an implementation strategy has an effect. On our pathway diagram here, the mechanism is simply a label for a process that explains how a strategy works to resolve a barrier, achieve implementation outcomes of interest. The mechanism should be conceptually aligned with the barrier, but it is an action as opposed to a state or a thing. In some ways, you can think of this as checking your assumptions that the strategy works in a way that holds promise of changing the state of the barrier. So enter our example. The decision support prompt in the EHR must enhance the salience of depression in that appointment. Even if the patient didn't bring it up, it must enhance the salience of depression, cut through the divided attention of the clinician to have them be reminded, administer the PHQ-9, and over time, rates of depression screening increase. Implementation mechanisms are, for some, a newer concept. So I wanted to spend some time here. It is also the title of my talk. So let's let's play a game, shall we? I'm going to put in front of you determinants of practice that you're probably seeing in your implementation initiatives. And I'm going to ask you, what is a promising strategy to overcome those determinants? And you get a clue. The picture is your clue. So let's start with our first of 4 examples. What is a promising strategy to address insufficient knowledge or negative attitudes about an evidence-based practice? I'd like to see your responses in the chat, please. Education's coming up. Do others have suggestions of a strategy that holds promise to address insufficient knowledge? Looks like Melanie might take the cake on this one. Others perhaps are simply in agreement. We'll see if it gets a little trickier as we move along. Thank you. Training, role models in practice, feedback, examples, bedside training. I like the specificity that people are bringing into this role modeling, because the operationalization of a strategy really matters for the strength of influence, for the efficiency of the strategy, and for equity. So indeed, you all were leaning towards what I think is a promising strategy: training, education, role modeling, feedback, to address a knowledge deficit. And it may do so by acquiring new knowledge. I want to highlight the implementation outcome here, that we centered adoption. And I did not put fidelity to an evidence-based intervention, because should training alone lead to skill enhancement? Possibly not, unless it includes what some of you wrote about role modeling and feedback over time, repeated dose. So that's our first try. Let's take another example. In this case, our determinants are organizational inertia, indifference, or resistance. What might be a promising strategy to overcome these determinants? Please put your responses in the chat. Reminders, an advisory board, involvement of stakeholders, focus groups. I see more diversity, ask for barriers within the responses here. And I think that's a nice illustration that there could be several promising strategies to address the same determinant. And so then you have to make some difficult decisions. Let's see what this group, our team, thought would be a very promising strategy: championing activities. So perhaps an internal clinician champion, talking about, bringing up, showing data, as Antoinette suggested, about the importance of an evidence-based intervention. That might operate through enhancing buy-in and potential efficacy among their teammates to lead to initial evidence-based practice use and growing skills, but again, probably not fidelity, full penetration, or sustainment by championing activities alone. 3 of 4, what might be a promising strategy for low practice change capability? So I'm looking to the chat for ideas about promising strategies for overcoming low practice change capability. Extra financing, okay. Other suggestions? Facilitating. Any other ideas? Flow of care, extra staff. What I like as we move through these examples is there's clear differences in strategies coming up for people, because again, you're trying to match to the barrier or to the determinant. And so our team thought practice facilitation would hold good promise of overcoming low practice change capability by building QI capacity and enhancing memory, motivation, and opportunity. Here's our final example. What might be a promising strategy for having unknown or inaccurate perception of performance? I'm looking to the chat for ideas of a promising strategy. We have audit and feedback, quality indicators, other suggestions, QI, audit and feedback again, benchmarking. Yes. It's interesting. Sometimes we use different terms for similar activities, and that's where our specification of strategies comes into play and becomes very important. Our team did suggest that audit and feedback held a lot of promise for overcoming this barrier of unknown or inaccurate performance by the mechanism of highlighting a performance discrepancy. So this idea that audit and feedback functions by highlighting performance discrepancy to overcome unknown or inaccurate performance that might get us to guideline adherence. So we've now constructed what our team thinks of as the trunk of the CPD, of the causal pathway diagram. So far, the case that I've been building is largely focused on causal pathways for impact, not your group, but like an effect. So causal pathways for having a large effect. The mechanism here in this example is that we're enhancing salience to address divided attention and get to our depression screening guideline. So in addition to driving for impact, we can drive for equity. So you can do so by staying with this trunk and actually centering an equity-focused outcome. So some people think about penetration or reach as being an equity-focused outcome. It certainly can be. I want to caution folks, it isn't inherently. You need to articulate, operationalize it to be an equity-focused outcome. And in this concrete example, I suggest that also with depression screening, we want to reach underserved groups. And when we were in a particular setting, what was one of the barriers? They spoke a language other than English. So the strategy was to assess language needs and curate the PHQ-9 in a host of languages. And the mechanism was to ease the access to other languages. And we have proximal outcomes such as seeing that PHQ-9s in multiple languages were in the waiting room, that staff were actually making sure these versions were in the waiting room. And you start to see data come in to the electronic health record that PHQ-9s are being completed in other languages. And that might help us achieve an equity outcome or goal. I want to acknowledge at this point, there's really nothing special about the shapes in the diagrams here or the distance between the arrows. Some of that's just the fact that I'm not very creative and that PowerPoint is only so big. But I want to create opportunity to do this work of slowing down and thinking causally in another way. You can do it in a table, for instance. You can see on your slide, you can start with the implementation outcome on the right-hand side, and then you can choose your strategy to get to that outcome, but you can really only choose your strategy if you know a local determinant, and if you're very careful in thinking about the mechanism to do that conceptual link. Education works through awareness building, knowledge acquisition to overcome a knowledge deficit that has promise in achieving feasibility, acceptability, appropriateness, and perhaps adoption of an evidence-based practice. Training, in this case, teaching and practice with corrective feedback, can work through acquiring and refining skill and growing mastery to overcome provider skill deficit. And that might lead to fidelity of an evidence-based practice. A train the trainer strategy works through embedding expertise locally. That can address turnover, which is so rampant and undermines our sustainability. A clinical champion-led implementation team can foster implementation climate to address provider engagement and get us toward increasing feasibility, perceptions of acceptability, perceptions of appropriateness of an evidence-based practice. And guidelines can improve clarity of clinical care. They can address unstandardized clinical care options and perhaps get us toward fidelity. So I'm moving on to make things a little more complex. We are not done with the trunk of a CPD with the causal pathway diagram. There are branches that are critically important, particularly for optimizing for efficiency and for equity. Our team hasn't seen folks thinking super carefully about these factors when they're building their implementation approach, and they can really threaten the success of an initiative, particularly for low resource settings. So preconditions are a new factor in our causal pathway diagram. They're the factors that are necessary for a mechanism to be activated and for subsequent causal events to occur. I want you to think about these as a light switch. They're either turned on or they're turned off. So let's look at an example of preconditions. We can put them at various places along the causal pathway. A precondition for mechanism activation is that the EHR prompt is noticeable. If it's built into a place on the electronic health record that is not part of standard work for a clinician, it won't be noticeable. It cannot enhance the salience. It will not overcome the barrier. It's either on or off. We also need to have PHQ-9 forms, available for them to achieve the outcome of increasing depression screening rates. Without PHQ-9 forms, these are the patient health questionnaire, I should have said that earlier, to screen for depression. Without them being available, patients can't complete them. We cannot get to our depression screening rate goals. The final term I will introduce today is that of a moderator. So moderators are other branches that are also critical for efficiency and equity. They can also influence impact. I want you to think of these as dimmers. So my colleague Brian Weiner made this differentiation between preconditions are light switches on and off. Moderators are dimmers that you can turn up the impact or down. So to go to our example, this is a trunk with all of the leaves and branches now. A moderator of this particular implementation strategy is habituation to prompts. Some clinicians might habituate to prompts more easily than others, depending on how the prompt is built into the workflow. That can actually dial down the impact of the strategy. The clinic visit length, if some clinician has gotten behind during the day, they might be less likely to engage in depression screening and prioritize other activities. If the length is retained, that might make it more likely to engage in depression screening. If you're interested in guidance on how to create causal pathway diagrams, this is an early publication from our team in how we were thinking about them at the time. It was published in 2018. We have an update, a methodology paper that we hope will be under peer review soon. and it has lots of case examples, and I think will be practically quite useful. Feel free to email me about that if you're interested. I'll finish out by underscoring the practical significance of featuring mechanisms in your implementation initiatives. I think about mechanisms as being helpful in the starting place of selecting strategies. So think about this. We have compilations of over 100 discrete strategies from which to choose. How do you choose among those? I think some people might consider those higher level categories. Perhaps they think to themselves, it's certainly something in the planning category I need, or no, we're in education space, or actually I need to change structure. I think other people might consider levels of influence. I need to target an individual, or I need to target a team, or I need to target an organization. I argue that implicitly what is happening in all of these examples is that people are thinking about mechanisms. How does the strategy work to overcome a determinant to achieve an outcome? How is that happening? And that's how you can make selection easier. I always think examples are helpful. So here's one. We have a distal implementation outcome of improving human papillomavirus screening rates to prevent cervical cancer. We have a detected barrier of risk perception. People with cervixes are not thinking that they're at risk for HPV or cancer. So the mechanism we need to activate is personalizing that risk. We need to make it meaningful for each individual. How might we do that? We could provide data. We could offer testimonials. And each of those strategies, as you noted, they're different. They might have more or less impact, but both could work to activate personalization of risk. I also think centering mechanisms can help with matching. It's very similar to selecting, but it is getting even more precise. The process of pairing a strategy with a prioritized determinant of a local context. How do you check that conceptual link is there and the promise of impact is strong? Take an example where breast cancer screening in African American or Black women is the goal. And the barrier that has been surfaced is valid mistrust of the health system. I have a team who is piloting the chatbot to achieve that goal, that outcome of increasing breast cancer screening rates in Black women. And they said this would overcome trust. I was skeptical. They articulated that a chatbot could actually validate concerns. They're testing this. They said also, we know a barrier is ease of scheduling. They said, guess what? A chatbot can surface appointments in real time. So this is an example where surfacing barriers and selecting strategies, how the chatbot is operationalized is critical to activating those very different mechanisms, because if it's only operationalized to surface appointments, they certainly won't overcome the trust issue and get to scheduling occurring. I also think that mechanisms, when they're centered, can help us tailor our strategies, which is the process of fitting or adapting a strategy to the local context based on resources and preferences and contextual constraints. So I argue to do this well, we must retain the strategy's core function based on what you know about the mechanism. So you can change the form, but not the function, in Brian Mittman's in his words. For example, Here's our depression screening rates example that we saw earlier, trying to, in this case, address a barrier of accurate knowledge of performance. Many of you guessed right that, well, you weren't guessing, you were making an educated opinion, an offering that audit and feedback can highlight performance discrepancy, address a barrier of accurate knowledge of performance. How does mechanism help us tailor here? Well, some systems have electronic health records and an analyst team that can create audit and feedback reports like this. Other systems do not have an electronic health record at all. If you know what your job is, it's to activate a performance discrepancy. It's to highlight that. Audit and feedback can take lots of different forms, can't it? It can be quite manual in terms of its production, and you can overcome that barrier of accurate knowledge of performance. And the final example, practical function that I'll highlight today is optimizing our strategies. So you can optimize for all sorts of different criteria or objectives. Please do look at Linda Collins's work in MOST, the multi-phase optimization strategy. She has this really neat article with Kate Westafaro, published in Implementation Research and Practice, that brings MOST together with implementation science. Their optimization objectives are characterized by an acronym EASE, that's efficiency, affordability, scalability, and effect. You could also optimize for equity. But as an example, let's say we're trying to improve service penetration of a practice. We have low practice change capability. We are going to use practice facilitation. Well, look at the bottom here. There are so many activities that are part of effective practice facilitation. Not every setting can take that on. Not every setting can afford a practice facilitator or can afford to bring a whole team offline to engage in all the parts of a plan, do, study, act cycle. So if we know we need to enhance motivation, memory, and opportunity and overcome low practice change capability, we might be able to streamline some of the practice facilitation activities to deploy only those that are needed to achieve the outcome of reach. So, as I wrap this up, I have a warning to offer you. My warning is causal pathway diagrams are artificially linear and overly simplistic by design. That is on purpose. We feature discrete implementation strategies as a way to slow down because you can't afford not to. When we start an initiative and we engage our partners, we hear on average 50 determinants of practice. That is more than we can feasibly address. We try to winnow those down with prioritization activities, often in a collaborative way, where we rate for things like importance or feasibility or equity. Then we get down to perhaps a feasible number of of barriers or determinants to address. And we go through the hard work of building an implementation plan. Our team suggests if you take determinant by determinant and on the back of a napkin, write down a CPD, going through that exercise, checking your assumptions, will help you design the most promising and parsimonious implementation plan. You can build CPDs to be as complex as you need them to be to reflect your reality. But starting simply is very respectful of our practice partners. I mentioned this article at the start, but just to underscore that when we completed this systematic review, we saw that the field was using such different terms to talk about their pathways that it was actually very hard for us to synthesize the literature. So that is one call to action for the field, is to try to come together around how we conceptualize implementation strategy pathways so that we can curate evidence for the field. And that wasn't the only challenge that surfaced out of this systematic review. We conducted a concept mapping exercise that revealed the following challenges to advancing the study of implementation mechanisms. There were challenges I just mentioned with accumulating knowledge and articulating these strategy mechanism determinant outcome linkages. Conceptualization and measurement are challenging. Bringing in theory, complexity, causality and context, and methodology and design. All hard things for advancing the study of mechanisms. We have what's called an R13. That's a conference grant from the Agency for Healthcare Research and Quality. And we've articulated a research agenda to advance the study of implementation mechanisms that will be submitted for peer review in the coming months. So stay tuned for that. I see a question in the chat and I'm ready to take those now that I'm done with my presentation. The concept map is such an interesting methodology and would take more time than I have to explain, but briefly, it's a multi-phased process that starts with brainstorming challenges or issues. And once the brainstorm is done, end users move the challenges into conceptually distinct piles using a software program online. And multidimensional scaling and hierarchical analysis actually then creates a map for you like this, where statements or challenges that the end users moved together consistently, they're closer together on the map, and they're conceptually distinct and labeled as such in the diagram, such as the one you see here. On that note, I will stop sharing and welcome further questions.
Dr. Lewis, wholehearted thank you. This was absolutely brilliant, clear. You took us step by step, and I don't think you lost anybody on the way.
Well,
I hope so.
Feel free to ask clarifying questions in addition to application questions or critiques. We welcome them. What we talked about today is in draft form. It's a proposal, it's evolving. Through the implementation science centers that we have, we are testing the use of these CPDs and then refining a toolkit for broad dissemination. So if a toolkit is something you're interested in, please email me and I'm happy to share as long as you're willing to give feedback on it.
Excellent. Suzanne, would you like to ask a question?
Yes, Professor Lewis, many thanks for this super clear presentation. And yes, the Professor De Gies is right, you didn't lose us, not for 1 second. I have a question about...
So, can you just introduce yourself briefly?
Yes, of course.
It's always nice. It's just...
Yeah, definitely. Sorry. So my name is Suzanne. I'm a postdoc at the Institute of Nursing Science. I work on an implementation science project. It's called INSPIRE. And this project aims at developing and evaluating a community integrated care model designed for older adults in one of the cantons in Switzerland. We've completed the feasibility. And when we looked back at the outcomes and the strategies we used, now we're ready to start analyzing, moving into the second phase. We realized that we had a bundle of strategies to overcome certain barriers, and our outcome is to optimize reach. And we realized that reach was very low. So going back and reflecting on the bundles we used in order to kind of improve for the next phase, which is the effectiveness of this model, so what kind of tips can you give us to judge whether the bundle of strategies used was wrong, or we made something like we can fix something during the pathway. So whether was it the mechanism that we failed, or was it the strategy, implementation strategy that was not optimal? So how can we evaluate in terms
Sure.
of reach?
To me, this is a very nice use case for a causal pathway diagram, where you're starting at the end with reach and thinking back through early signals, and did we see them? And thinking back further in the trunk to the specific barrier or barriers to reach. And that is likely a very rich stakeholder engaged conversation to hear from them. And stakeholders in this case might be community members, if I understand your setting correctly. They might be the right ones to share their lived experience with you to surface the barriers to reach. But then once you've surfaced the barriers to reach, which perhaps you've done already, but you're scrutinizing it as a thought exercise with your stakeholders at the table, you might start to see that there are moderators that are actually really hard at work that didn't have a strategy in your bundle to address. So for example, you had a precondition for a strategy that wasn't in place in the community once your research team pulled back, for example. So it's scrutinizing kind of each part of the pathway to see, was that in place? Was it addressed? Did we miss something? And so it sounds like you're already engaged in that critical exercise, but I wonder if thinking about each factor precisely and how they fit together, if that might lift up some ideas that you didn't have when you were thinking about it as a whole. Does that help?
Yes, of course. Thank you.
And in the toolkit, we have a formative evaluation example that we're building. So if you'd like to see that, please email me.
Thank you.
So why don't we go to Christina Keen, who also has a question in the chat. Christina, if you can unmute yourself and tell us where you're from and repeat your question, please. Christina Keen. A second, please. Of course, Christina, we have a second for you.
I see in the chat just also this emphasis on engaging the community wherever possible. And I didn't talk about engagement in the talk because there's so much we could discuss, but agreeing with the comments in the chat that the community, our stakeholders, their lived experience, their voice are critical at so many points along the pathway. And thinking through when and for what purpose is the most respectful thing we can do, right? You know, their lived experience to contextualize determinants, I think is very important. Having them start with the outcomes that they care most about, having them tell you what their contextual constraints are so that they can help you operationalize a strategy in a way that works for them, all very important.
Thank you. Christina, are you ready? Otherwise, we will just repeat. Christina, if you're there, could you just introduce yourself and repeat your question?
Yeah. Hello, I'm sorry. The internet connection was disrupted. My name is Christina, and I'm from Austria from the University for Continuing Education in Krems. And my question was regarding the determinants. So the number of determinants which can be kind of addressed within the research project or within an implementation project, because we're soon starting with a de-implementation project. There might be similarities. And therefore, I was wondering if there is a kind of a rule of thumb about how many determinants can reasonably be addressed within an implementation project.
Thank you for that question. I have a lot of thoughts about it. My first thing I'd like to say is that even though I myself have done this in the past, I discourage rating determinants for their addressability. I think it's appropriate to do, and it's probably not the right starting place. And I say that because I think we often, in an implementation initiative, go after those low-hanging fruit, those easily addressed barriers, and we might spend some time and resources there, and they might not be critical for impact. So that's the first comment, is to be really thoughtful about what parameters you apply when you are trying to prioritize barriers. And when I mention toolkits, I'll mention another one. Brian Weiner has developed a toolkit for barrier prioritization, and he has scales and different parameters for what you might apply when you're doing this stakeholder engaged work. So feel free to reach out to me about that, and we'd be happy to share. The other thing I would say, to your point, and it sounds like this is your experience as well, where you surface more barriers than you possibly can address. So you immediately go to feasibility, but I will channel Brian Weiner again. He thinks a lot about this space, to say that we so often prioritize barriers in isolation. So we fail to recognize their interdependence. So that's another interesting thing to think about as you solicit barriers. How are they related to one another? If you address one, might you actually have almost this cascade that addresses others? Or if you don't address one, will that, make all of your other efforts fail? You could bring theorizing into thinking about determinants. That's another way to approach this. But in terms of there being a sweet spot on the right number of barriers to prioritize, that actually might be a stakeholder, conversation to have, and not necessarily a rule of thumb that I can offer. Some settings are very well resourced. They might have an easy strategy to deploy that could actually address lots of different determinants. That's one of the things that can be kind of cool about doing separate CPDs, is that you start to see, oh, this one strategy has promise of addressing 6 determinants. I'm going to deploy that one. That's a lot of bang for my buck. So I think that if we take each in turn and we see a strategy showing up again and again, we might actually be able to address more determinants than if we had started just with the host of determinants and then tried to, as a package, design the plan.
Yeah, thanks a lot.
So I will give the word to Hélène Schoemans. Hélène, would you like to ask your question?
Oops, hey, can you hear me?
Yes, you can.
Good. Hi, Hélène Schoemans. I'm a transplant physician from Belgium, an ex-PhD student from Sabina's. Thank you for this great talk. I was wondering if you wanted to comment on how on stakeholder engagement frameworks, and whether you have any recommendations as to which ones to use, and references in the literature about this.
Thank you for that question. And I wish I had a very succinct and direct response, and I don't, unfortunately. So it's certainly something that I think a lot about, and have appreciated in my earlier days, in particular, the community partnered participatory research, where that has been quite helpful in thinking through out of the gates. Before you even know there's an implementation initiative, you have your partner's values centered, and they're co-designing and driving the goals. So I suppose that would be CPPR is a model that I've really appreciated. But there is a lot of excellent writing in the stakeholder engagement space, And I will just acknowledge, I think there are empirical questions about how to engage stakeholders and when. And so, for example, I think that the status quo around surfacing barriers is perhaps, what's the right way to characterize it? Maybe an insufficient way to approach it. And when I say the status quo, you often see a handful of surveys or key informant interviews. I think that those methods are sort of riddled with bias. And if we can figure out more rapid ways to take on a more ethnographic lens, that could be, that could hold promise for a method for engaging stakeholders for barrier identification. I mentioned that I do think that stakeholders are really important when articulating outcomes at the outset and also for prioritizing barriers. And I think that stakeholders may be less, depending on who they are, but they may be less skilled or ready to select the implementation strategies and articulate their mechanisms. I think, and this again is an empirical question, but I think stakeholders who might themselves be clinical practice experts, they're clinicians, they're champions, were they trained in organizational change management? In many cases, they're not. So this is where the science of implementation becomes practical, and we as research teams supporting our partners can articulate an initial plan and get their feedback, and where their expertise really comes into play is operationalizing the strategy. So you could say, in this case, education's not needed. Knowledge was not a barrier, but really what we saw was relative priority is a barrier. There are so many competing demands. So we need a strategy like clinician-led meetings, because we need to build implementation climate. We need to show that this evidence-based practice is expected, rewarded, and supported. And so you can offer the evidence that, like, to overcome relative priority, you need to activate implementation climate. There's a promising strategy, but then they decide, how do we operationalize that? Who's the clinician? When are they bringing people together? What are they talking about? At what cadence? And so on. So I guess all of that to say, stakeholders matter. It's all about them. They should get us started, and we should bring our expertise and evidence in to make their job easier so that we leverage their voice when they have the expertise on the topic. And I saw someone mentioning Alison Metz's work on the stakeholder engagement front, and I agree. She and her team have done an excellent job in that space.
Thank you so much for taking all that time to help me forward. Thank you.
Cheers.
So, Dr. Lewis, from my side, I would like to ask you. I mean, you very nicely at the beginning outlined, how implantation science has evolved over the past, let's say, decades. Now coming to mechanisms. Very important work needs to be done. One of the questions I have is, are we working the right paradigm? Because you have indicated at the end that, yes, it's an oversimplification, it's linear, and you see a number of scientists who now embrace system science. And I would like you to comment on the promise of system science in implantation projects, because it is adding complexity, but embracing the right methods in order to address complexity. And there is a very interesting work out of economics that has shown that by using system time, systems mapping, that this can tremendously help to find the right level at which you address, in the end, your implantation strategies. So, to some extent, there is still a lot of, I would say, it's stakeholder involvement, there is discussion, but there are methods that allow to really kind of have a much even better informed way to determine, where to kind of start, and inspired by system science. So looking
Sure.
forward to see if that might be the next phase in implantation science.
Sure. Thank you for your reflections. They're quite insightful. And I am not a system science expert. I have read a fair amount and have curiosity as well. So my comments are coming from that place. What I think is that system science absolutely holds promise for our field. And to your point, it can lead us to solutions in an engaged way, relatively efficiently. I hope that more and more people train in system science so that they can build an evidence base that can be used to practically guide implementation initiatives. I'm not sure everyone will become facile in system science for it to proliferate across the field as fully as it would need to in order to have a paradigm shift. So that's a challenge maybe for the field to take on. In lieu of that, what we're trying to do is help people think causally and slow down so that they can think about how things relate to one another and have a more practical way of approaching this. And I'll also say, I think there's different purposes. So not to defend what we have and, say it's better or more than or whatever than system science, but there's different purposes, I think. The complexity is real in our implementation initiatives. System science can handle that. And the inputs to strategies and how they work could be thought of as basic science on discrete strategies to then input them into system science approaches. That might be completely naive of me to say, but that is something that I'm thinking through, that there are different purposes, and system science can be a solution. And is it for everyone and every community setting? Perhaps not.
Are there other reflections, remarks, people that would like to share their own experience, their perhaps absolutely their own insights, or how they have resolved certain ways forward in kind of going through this path from making the invisible visible, because this is in the end what you're suggesting, and creating an evidence base that allows us to then move forward. So as nobody is currently reacting, I would like to now go to the more practical side. I mean, it's clear that implantation should be on the radar screen of all healthcare professionals, because a lot of education is just focusing on teaching the evidence, but in the end, evidence needs to be used, needs to be implemented in order to have an effect. You have talked about, there is this local context in which you have to do the analysis and see what is it here that will, in the end, that needs to be taken up and included in your thinking. So if you think about a successful project in view of implantation in one local context, using this approach, making visible the invisible, informing really how things work. And then you go to the next phase, people who want to scale it up from 2 sites to 20 sites. Bottom line, does it mean to take always a step back? It means not jumping to conclusions. There is a kind of loop that needs to be made for, let's say, each new center, each new setting, because you know this element of the adaptation, which is absolutely part of a successful project. So could you, because this is for those who are out there in the front line, our colleagues who don't have time, you know, they see something successful, they want to take it, implement it, check box certain strategies. And so how can we motivate them to continue with these efforts while at the same time slowing down?
Yes, such a good conversation topic, and so much to discuss. A thought occurred to me that I wanted to share. This to me is again an empirical question, so I hope someone will study it if they think it's important too. But as we design our implementation plans, I think that the pairing between the evidence-based intervention and the intended setting, that in and of itself might inform a core set of strategies. So we haven't really talked about this, like we talked about the implementation outcome and the determinant should inform the strategy design. But I actually think, I'm not sure, but I think that an intervention with the target setting together would tell you, okay, it's a psychosocial intervention. You absolutely must have training and feedback. Like you can't just audit and feedback a psychosocial intervention into fidelity. Just that's not a thing. So, and I think also if something, you know, if an intervention is intended to go into a team-based setting, well, you can't just do individual targeted strategies because they need to learn to work as a team about it. So that's my first starting place when you think about scaling. So designing and then scaling strategies, I think the core set of strategies based on the intervention and the setting might be scalable. They might have to be adjusted somewhat in the form, depending, because we know even within one organization, a hospital A looks different than a hospital B, but there's some version of the core set that might be scalable. And then I do think that there's not good return on investment evidence in our field. So to your point, how do you build the case that organizations, agencies, clinics, schools, hospitals, programs need to slow down to scale? That's really hard to do when people are looking for a return on investment in the implementation process. So that's another call to action. I'm not making it for the first time, but I do hope we see more economists bringing in costing into our empirical investigations. And then I think that there is some good evidence of impact or lack thereof by attempting to scale without informing the efforts based on local evidence and constraints. So the extent to which you have a partnership and they respect you and you have talking points around evidence of the need to contextualize the strategies to scale, that can help. I have one example of that personally that I now use as a testimonial in other work that I do, where we actually slowed down for 8 months and then had wild success on something that was very hard to do. And folks were impatient and didn't want to slow down, but they trusted me and they did. And so I think that we have some evidence on impact, not enough on economics, and a lot more work to do, but.
So I hear you say slowing down is an implementation strategy in itself. And I do agree. I mean, it is, but that's something that of course also needs budget. And typically projects are very much determined by project times budget. I see Suzanne Daini who would like to join the discussion. Suzanne?
Not really, Sabina. I'm just nodding my head that I agree with slowing down. Yeah.
I think we can operationalize what slowing down means, and then we can call it strategies. It might be a local needs assessment, for example. It might even be remapping the strategy plan to the constraints and resources of a local context. So I think I agree with the sentiment of slowing down, and it's precisely what are we doing in that time and how do we justify it? And what will it serve us in the long term to be able to do? And you're right, our funding structures are misaligned with the work that needs to be done. And so re-envisioning study timelines to allow us to create this evidence, to test these processes, these phases that we think are critical, will be important, I think, to really have the success stories that our field deserves, given what it set out to do.
And success stories, there are more and more, which we can celebrate.
Certainly.
So the methods do result in the end in impact. And so I see that there is one last question. Marie, I think it's, yes, please go ahead.
Hello, my name is Marie Schneider from Switzerland, and I have a very small question for you. It's about publishing testimonies of slowing down. I think that would be very useful in the literature.
Sure. Amy Kilborn and a couple of colleagues have a success stories paper that I can find and put in the chat. And then the other example, it's just a personal one. I just sort of mentioned it. We were invited to write 3 papers about our 3 phases of implementing cognitive behavioral therapy in a milieu-based team environment by lay health workers in youth residential settings. So it was a very low resource setting. It was a highly complex environment. And we were able to get them to slow down and spend time in preparation before they went to implementation and before they went to scale and sustain. And so that's obviously a salient story to me, but I think there are probably others that I'd love to hear about.
Thank you.
So Dr. Lewis, wonderful you joined us in Switzerland. It was a fantastic webinar to start our series of this year. A wholehearted thank you. Your email, we can also put, Juliane, perhaps in the chat box, just to make sure that there is an opportunity to connect with Dr. Lewis. All of you who have participated in this webinar, and there were many today, I would like also to thank, to join not only from Switzerland, but also from other countries. We will have our next webinar, the 3rd of May, from 5 to 6:30 Central European Time, and we will advertise that in the coming time. So wherever you are in the world, be it in the US, be it in Africa, be it in Australia, be it in Europe, have a very nice rest of the day, night, morning, afternoon. Dr. Lewis, wonderful, thank you. And so we look forward for our virtual audience to come again in the 3rd of May from 5 to 6:30 Central European Time. Impact will inform you in due time. And also a wholehearted thank you to the team who organized this webinar, and specifically Juliane Barnik and also Juliane Mielke. Thank you so much.